Good day, everyone. My name is Skender Darity, and I welcome you to another installment of the Value Analysis Expert Series. We are joined by three of the most renowned value analysis expert in all the land, starting with Terry Nelson, Barbara Strain, and Janelle Robinson. Welcome, ladies, to another installment. Thank you.
Thank you.
Thank you.
So, in this installment, we're doing this right now, we're in mid-February 2025. Clearly, there's a lot going on in the world around healthcare, macroeconomics, geopolitical dynamics that are going on. And one of the key things that I was thinking about in leading into this call was just reading through some of the provider earnings. Okay, and one of the things that I think is probably a hot topic for each of you is whether you're in positions of value analysis currently or you're consulting others in value analysis strategy, looking at the earnings from just Mass General and Catholic Health Systems. Mass General saw a 17% increase in supply costs. Okay, that was in their first quarter, which is typically calendar Q4, but in their first quarter, it was a 17% increase in supply costs. Catholic Health Systems had, I think it was about a 9% increase in supply costs, right? So I've got a series of questions to ask you because I'm just so curious about this and so many elements, and I know so many of our listeners are too. But help us understand, these supply costs, they're not going down anytime soon. How does value analysis work to help kind of stem that tide, if you will, in as much as possible? Barbara, you want to kick that off?
So let me kick that off. What you have to do is, Terry, don't start in already.
I'm sorry.
Anyway, what you have to do is, as a provider, you've got to look internally, where can I streamline a variety of things? And I don't mean you go in and, lay off a bunch of people, or you don't do procedures.
But that's what's coming.
I don't know. But you don't do procedures in something area. What you need to do is you really need to look at, do I have 5 of the same things, and what's the reason I have them? Or am I doing pretty simple procedures, say in the OR, cath lab, cardiology, but all of my practitioners in there are all doing it differently and consuming things differently? And what do we really need to look at? Because value analysis is trained to really look at the overall picture, not just what's the next product you want me to look at that you want to bring in. That's not what we're about. It's all about creating our own value internally to the point that we can.
So, Terry, with 17% rise in cost, can you create that value? Is there a chance to do that?
Yeah, I think I appreciate you sharing that example, because it's like, oh my goodness, right? That's the response that people get. But you need to know what's in that supply cost. I mean, is pharmacy included in that, which we know the increase in pharmaceuticals has happened over the last 5-10 years. It just continually, steadily goes. So understanding what that means, and I think that's part of also what value analysis does. What are the categories that are included in your increased cost? What has increased? And then linking them up to populations, right? So if your oncology care cost has increased, especially in pharmacy, which it has for many organizations, then is my patient population increasing, and what does that look like? The same thing with, are your procedures increasing? And that goes into your OR products and services. So that, just to underline again what Barbara said, value analysis is more than just a new product you want to come in and we guard it. We really are looking at all of those factors that drive not just what the provider says, but then how it marries up with the right supplier.
Janelle, what's your take on that?
I wholeheartedly agree with both of them. I think one of the things that is probably scrutinized a little more now as costs are rising is variance in care and variance in technique and procedure. different hospitals operate differently. You have your academic medical centers that may have a little longer procedure time, therefore a little higher costs. You may have specialty facilities that they can crank them out. They do the same procedures day in, day out, or same grouping of procedures day in and day out. So there really is also a variance in care. And along with, I think what Barbara said, that also creates a variance in types of items that are used. And one of the things that we look at in value analysis, when you start talking about or start looking into these procedures and the costs, and physician A uses this, physician B uses this, are they really the same? Can they be the same? Can we almost looking at it as like a group purchase within our own organization? How can we leverage the power of purchasing and to help drive some of those costs down? Do we need 10 vendors for 2 like items? Can we, we don't want to completely sole source, because we do understand and appreciate variances in patient and different patient anatomic, anatomies that need different things. But do we really need 10? And so it's also getting back to that. And what are the outcomes associated with each of these? Cheap is never a good word to use in healthcare. It really isn't. Let's use cost. Yeah. So look at the cost effectiveness versus the outcomes that are associated with it, because outcomes also, looking into the future also plays a very large part of value analysis and the decisions we make today that affect the outcomes of tomorrow.
Can I just add to,
Yeah.
I'm sorry, I just wanted to add, because I thought Janelle said something that I want the audience to understand, that we do agree with each other, but our perspectives are always a little bit different. So we have a lot of value analysis experience between the 3 of us, and we do agree, but how we get there. So I think that's important for individuals looking at the podcast to realize, just because Barbara, I had somebody recently, Barbara, say this to me. Well, I went to Barbara Strain and she said, and I said, I agree with Barbara, but your product is a different angle. And I'm just giving you my insight into that. And I think that's really important for suppliers to know, because it goes back to healthcare, right? Providers are all just a little bit different, but it doesn't mean they're wrong. And the other thing about, I promise the factor I wanted to bring up is something Janelle had said is, do you remember when we were doing a massive standardization for new physician hires and the requests, especially in the OR, right? On the equipment, the implants, the products they wanted to use for their procedures. And they were kind of given historically, now that's a good 25 years ago, probably, just wide open, whatever you want. I think that's going to shift also, because we have, we're struggling to get physicians in certain markets, right? And so having the availability, you may see leadership saying, I'm going to open the book to whatever they want to order. And that's where now we're going to have increased costs as well.
Yeah. So you said what you're saying is forget tariffs, forget rising supply costs, et cetera. Just getting back to a world where competing for physician labor might drive up supply expense.
Well, tariffs will too. I don't want to be on the end of that, having to increase costs because supplier has to pay for more.
Yeah. So I want to build on that for a second. So let's talk about that. I guess I want to demystify a little bit here the value analysis as it comes from a supplier perspective. Help me understand and help our audience understand, who does value analysis usually report into? Like what is the tree? And I'm not talking about the exact title, but what is the tree? Is it operate? Help us understand, who does it report into? So Janelle, who do you report into?
I think it's different at every organization. I am used to reporting up through financial services.
Financial services. Okay. So in some way, shape, or form, your ultimate boss is the CFO.
Correct.
Okay. How about you, Terry?
Yeah, that's similar for me. So our structure, where the organization I worked for, the structure was we had departments, and under departments we had divisions and what have you. So supply chain always reported up to the Department of Finance, which then reported to the CEO of the organization, right? So think about that. I just wanted to add in there, it's where value analysis is their chair. So I reported to the chair for sourcing, who reported to the chair for finance, who reported, chair of supply chain, who reported to finance. So it's 4 steps, right? So the closer you can be to the C-suite, the better it is to get your opinion across.
So basically, you said sourcing, which is an element of supply chain in some which way, is where you came in through, and then typically supply chain reports into finance. Understand?
Yes, correct.
So then, how about you, Barbara?
So I've had several different over my career was longer because, I'm older. But it switched back and forth between the COO or administrative line or the finance line. And I think it depended on who was actually probably the CEO at the time or the strengths or whatever, where those individuals came from. But I reported to what's the equivalent of the chief of supply chain, so whatever you call them. And then they reported to the CEO. Or the last reporting structure I had was probably the best of both worlds. I reported into supply chain with a dotted line to finance. So every other week I met with those different leaders so that we could educate each other as well as communicate with each other, and how we could then formulate what we were going to do with all of the other chiefs and administrative business directors and things, so that we could really make an impact.
Okay. But so the largely uniform answer is in some way, shape, or form going into finance, and therefore some sort of uniformity across finance, reporting into supply chain, and then within that finance vertical, Barbara, obviously you had some deviation potentially, and at times reporting into operations. Okay, so we talk to our clients a lot about the dynamics of CFO. Clinical, financial, operational. If you are going to do anything in presenting to not just value analysis, just presenting technology to healthcare today, you better have that 3-legged stool solid. Okay. So let me ask you from a supplier perspective, if value analysis and those that have the official title of value analysis in some way, shape, or form always report up through finance, how is it that you can be held honest to the C portion of that clinical portion? How does that create equal? And we all have, under some way, shape, or form, a Hippocratic oath. I get it. We all want to do well by the patient. We all want to do well. But if the CFO is signing your checks and his incentive is drop supply costs in whatever way, how does clinical get equal metric in that from a value analysis standpoint? Terry, you want to take that first?
Yeah. Oh, thank you, because I was just edging for that. It's the clinical part of value analysis. The stool has 3 legs, but we also are clinically bound. And at least my experience being in the supply chain world was being a nurse. My first relationship is to the clinical area. That just came naturally to me over the years. So they are a customer. The biggest customer value analysis has is the clinical arena, no matter what it is, whether it's the OR, radiology, direct patient care, outpatient care. And that always has to lead into that. If you can position yourself in value analysis between that, understanding financial and clinical, you'll always make the right decision. And you really will, because you'll bring outcomes and other things into that. You'll make it, and you'll be able to articulate why the product was approved for clinical and why it wasn't, right? You don't have to use the argument, it's just cost. You can say, here's the clinical rationale for it.
Interesting. I've got another question I'm going to put a pin in because I want to hear Barbara and Janelle's answers. Barbara?
Sure. To echo what Terry said, is if you keep the patient, whether they're an inpatient, outpatient, whatever, at the focus, you will not make the wrong decision, because you're going to be focusing on what's the most important. And then the next is the caregiver. and what's happening in their workflow and things. And then it's who are the others that are interacting, et cetera, to the ancillary areas, labs, radiology. It's that lineage to the patient that you keep at the center. And if you're doing things for the right reason, then you'll have those, I'm going to say kumbaya moments, is that everybody wins in that, because if you do it for the right reasons, your finances will improve. Length of stay, whatever you're talking about, quality, you won't have a lot of outpatient, episodes. You won't have a lot of drugs. You won't have a lot of tests going on if you do it as patient-centric.
Janelle, do you agree?
Completely. Barbara, you stole my thunder. You took it the rug right out from under me, and there went my words. She is 100% correct. A patient-focused decision-making backed by evidence is the strongest argument you can ever make for a product. Finances are what they are. There's essentially, especially in the DRG world, a set amount, and that it is what it is. So the patient-centered variables that you change in order to improve outcomes, reduce that length of stay, is going to come off the end, which ends up being sometimes a cost savings, but cost is defined more than monetary in my world, in my opinion. I mean, like Terry, I'm a nurse. And so the patient always is at the center of any decision, naturally, I think, that you make. But we also live in an evidence-based world. So it has to be backed by some kind of evidence to substantiate the value proposition. And when those, and as Barbara alluded to, when all of that is in line, you can't help but save on the end. You're either saving labor costs, saving, patient return visits. So there's more than just the monetary when you think of savings. And I think as a supplier, you need to kind of open your mind to that a little bit and think outside of the box, other than how much, there's that word, that C word, cheaper again. I hate that word in health. But how much more cost effective? Oh, it's cost effective. Okay, but to what extent? Because it can be more cost effective, but in the long run, doesn't have the outcomes as an incumbent product, then we've lost. Mm-hmm. We've lost on multiple fronts. So it's connecting all of those dots.
So Janelle, two-part question. Oh, do you feel like, because value analysis committees are made up of exactly that, right? Some clinical, some financial, some operational, and some component. Okay. Did you feel like those clinicians saw you as being on the same side of the table as them and having the same goals? And second, did you ever find yourself in a position in that term of cheaper? Did you ever find yourself in terms of at odds with the supply chain people or the finance people you're ultimately reporting to?
Yes and yes.
Okay.
Now, the first part of the question, it's always a little bit of a struggle when you're sitting on a committee or coordinating a committee or whatever your title is to gather all of this information for effective decision making. And you're seen as someone from financial services, but maybe I'm a little different. I also have a nursing background, so I can walk the walk, I can talk the talk, I can understand the outcomes. I've been there, lived there, been ingrained in it. So maybe it's an unfair question to me. It's a little different, where I've never really had that challenge. Now, the struggle with the second question, do we come across that? Absolutely, without a doubt. There's some inner consternation where I have a responsibility to my patients first and foremost. Does this improve outcomes? Is it what it's aiming to do? And then on the other hand, I also have an obligation to the health. I, meaning, as a value analysis professional, have an obligation to my healthcare system that I work for to be good stewards of the resources and of the money and to help make the right decisions and to bring it all together. So typically, what I found over the years is if an item is proposed that may be less expensive and is proposing the same outcomes, an evaluation usually kind of runs the course, and it kind of tells you if it really does perform as advertised. And it's it's actually very common practice to test the waters and dip your toe in a little bit before you make the final decision and bring on another supplier, bring on, an increase in your supply costs one way or the other. There's nothing wrong with that.
So Janelle
Barbara,
mentioned
same
something
two
a little
parts,
bit
yeah.
ago.
Go ahead. No, I was pointing it to you.
Janelle mentioned something a little bit ago that brought something to mind, is that it's not like we go from, you get the information and you go right to your team meeting. There is time in between where we're meeting one-on-one, small groups, and then they might mention something internally that says, I think you need to talk to so-and-so, or you realize that there's 3 other tracks that go down to this product. Because if the team just made a decision based on what the vendor gave us without us investigating internally, we might miss the fact that if we change this, it interrupts the way imaging gets done, or interrupts the normal values of a lab test or something like that. So we do all of this research and we go down all the rabbit holes. Now, I'm not a nurse, but I'm a clinical microbiologist. We had to do the same thing because we had a piece of the patient with us the whole time in the laboratory. And if the specimen wasn't collected correctly, or we didn't have trained people who knew how to find something, it can be a matter of life or death once you report those results. It changes everything. So those are the same investigated things you do as a value analysis. And then you go back to the supplier and you say, we have this circumstance here. Does it cover this? What do others that do? So we get outside resources to talk to other hospitals. We would talk to the Janelles and the Terrys and across the way if they were also using the product and converted to it. We get the real story. How did it work on these populations? So we're always fact finding.
So Terry, were you ever at odds with your bosses?
Never. I'm lying. I'm lying about that. To the phrase you said, bosses. We are facilitators of process. So yes, there were people that didn't like the outcomes that I worked with. But if we followed the process, and I would get calls, I'm sure all 3 of us got calls, and I would say, hey, let me get my data, let me get all the information, let's talk through it. And when that happened, almost 100% of the time, everybody was accepting. Okay, I didn't realize, and really underlining what Barbara just said, they didn't realize, oh, you did that and you did that. And this is what we found. And here's all of the information that you have going on, type of thing. The best one was when I said to one individual, we went through everything and he said, well, I still don't like it. And I said, well, the project was led, because we always look for clinical, by the chair of your department. Here's his name. And you can call him. And if he wants to talk about it more, we can. Never came back. I shouldn't have probably said that on this podcast, but
it's quite all right. You didn't say any names. We're okay.
No
we'll
name,
try to
no
get you to
name.
say a name later. Is it? Does it
I
start
think
with a
the
G?
point that we're trying to make is we go through a lot to make these decisions, and we get a consensus from all those key stakeholders and things, so that the suppliers out there, the manufacturers, the ones that have these new technologies and things, understand it's not just we just say no because someone told us we can't spend any money. It feels like that sometimes, and it depends on who you're talking to in a provider organization, and to find out how are they making decisions in that provider organization.
And sometimes we'll identify things that we never intended to. And along those lines of multiple, a decision that may affect multiple service lines, for example, is something you don't always think about. And then we'll go back to the vendor and, kind of talk it through with them. And they'll say, oh yeah, well, that's on our horizon. So sometimes it does take a little longer or a lot longer, depending, to pull all of the analysis and pull all of that information together, because we're also thinking outside the box and down the line. So we're not going to make a siloed decision, but make a decision for all if it affects multiple departments and affects multiple people.
So what I think is my biggest takeaway from the last 5 or so minutes that I've heard you say is basically value analysis is the one that provides the color commentary between the black and white of finance, of operations, of clinical, right? You're the ones that provide the filler, right? In black and white, it's yes or no, but it's not just yes or no. You have to sit there and tell the clinical team why there are financial implications, and then tell the finance team why there are clinical and operational implications, et cetera. Do you feel like that's an accurate representation? Janelle, you're
Yes.
nodding.
Absolutely. And art is subjective. So if you think of it as a colorful painting, the person who proposed it may not agree with your artist rendition, but it happens backed by data.
We're the middle person between the provider and the supplier, because Janelle and Barbara both had said, we want the supplier to be successful. But if you don't follow it and the timeline, we've all run into that where, well, we really want you to order product now. It's like, oh, we haven't finished it, right? We want you to be successful, you as a supplier. So we have to follow this process. And in the long run, it'll be better for you because we'll use your product longer than 30 days, right? So we are the middle people.
See, that's a really interesting concept, I think, to most of the supplier community, that value analysis can be your greatest advocate, right? I think people just think, unfortunately, and I'm speaking for those guys, not me, but a lot of people see value analysis as just being like, oh no, there's just a one big red stop sign. That's it. All they want me to do is stop. And I don't know if I can ever see that, but what you're saying here is you're an advocate to finance, an advocate to operations, an advocate to clinical, if they speak in your language, right? So I think the key takeaway here for our supplier community is understand that value analysis can be that glue that binds the whole process, but you have to be able to speak to them in that way. Would that be an accurate assessment?
Yes.
Yep, we can help put the story together, because I think everyone wants the best for their patients. They want the latest and greatest technology, that's available, and we're there to help them. We shouldn't be seen as a hindrance, rather as a help. We may ask you difficult questions, but we know how our committee thinks, and we know what the thought processes that run through our committee. So we're there to head off some of those difficult questions. So work with me, give me the information, and I will present it for you in the best way I can, armed with all of this data and all of this information.
I love that, because I think when people get those difficult questions from your people, they think you're gunning at them. Yeah. Instead, you're saying, I already know what's coming 3 steps down the line. That's really interesting. Terry,
we're the neutralizer. I was going to say we're the neutralizer because we have all worked with suppliers who have maybe weren't successful at some point in time in an organization. And so when you bring one of their products in, I've heard this where they've said, oh, that's a terrible company. They haven't even looked at the product. It's a terrible company. I don't want to do business with them. I don't like that. And it's like, no, we're going to start over again. We're going to start looking at it from this perspective. So we really help to neutralize that and ask the questions of why it failed before and what has been corrected, and then articulate that for them. So we are wonderful people.
If suppliers are willing to listen and make those corrections is a big deal. And sometimes they can make them very fast that we didn't even realize, right? Because they didn't have a really good focus group in why they did the product in the first place, or they rushed it out through marketing. Who knows? But everybody learns.
Really interesting. So, ladies, I know you're not going to believe this, but we have come to the top of the time here. It felt so fast. It always goes so fast. Why don't you each just leave us with one last thing that from today's discussion you want the audience to take away? Janelle, why don't you start us off?
This sounds so elementary, but value analysis professionals really are your friends. They're your shepherds to get through the organization. They're the shepherds that can help put your story together in a meaningful way that they know that their committee makes decisions. So, and just have patience with the process. Have patience. We're not worried about year ends. We're not worried about quarter ends. We're not worried about that. Just trust the process.
Love it. Terry?
Understand supply chain and its reporting relationships with products and services. That will help you to get to the right person that makes decisions finally. Not going to the CFO, not going to the CEO right away, but actually understanding supply chain.
Love it. Barbara?
Well, one of the things I hope the suppliers in the audience that are listening say, I need to go back and look at my material that I'm delivering. Am I customizing enough for the culture and what's going on at those customers I'm going to see today? Because they're not all alike, as you've heard, and they're not all going to be, but you can ask them those questions that we just presented you with information. So do you guys report up to supply chain? And what do I need to know about how you make clinical decisions? It's a way for them to look back at their approaches.
Yeah. Value analysis as advocates is like we are turning a whole new page. This is like dogs and cats getting along, Tom and Jerry being friends. I hope everybody on the supplier side really sees through this and sees that value analysis is your advocate. And they present value for you and asking the questions that maybe you're not getting directly from the other people. But as long as you come prepared and seek value analysis as your advocacy, you can really gain significant progress through the process with that. So, ladies, thank you once again for imparting this knowledge upon all of us. Really very much always appreciate each of you and your knowledge. And I think this is going to be an exciting series to come. With that, I do want to do a shameless plug for a webinar that we are going to be introducing on Tuesday, February 25th, called MedTech Momentum, where we have another panel of experts helping suppliers identify the challenges that go from concept to market and the commercialization process. And it's just another adjunct to this in helping suppliers really get a thorough understanding of the great picture. But the service that each of you is providing is very much appreciated by the community. I encourage everybody to listen to the series. Please reach out to each of the experts, and Terry, Janelle, and Barbara. They're there to provide their expertise as needed. And we appreciate everybody's time. Thank you for listening, and we look forward to catching up with you on another one.
Thank you.
Thank you.